Good morning, everyone. I'm John Tilbert from Mayo Clinic. Welcome to the session on shared decision-making, motivational interviewing, and behavioral change, Nexus of a New Paradigm. So I was a philosophy major in college, so I got to talk about paradigms. I don't think we're going to discuss Thomas Kuhn or anything this morning, although that could be fun. What we're hoping to do today is to have a conversation about different ways that different fields have talked about conversation. So it's fascinating to me where apparently different ghettos, so to speak, in the academic world or in the biomedical world tend to not speak to one another and then occasionally bump into each other and find curious congruences and questions. And we want to explore that today a little bit more. In the world of shared decision-making, we talk a lot about preference-sensitive and non-preference-sensitive decisions. In the world of behavior change, we talk about behavior initiation and behavior maintenance. And we don't necessarily see where these things intersect. We also, it seems to me, walk around with a set of presuppositions about what we think the underlying sort of theories are for the interventions that we implement, although it seems that sometimes the framers of those theories, their original intent gets lost. So, for instance, for myself, I had some 2-hour module on motivational interviewing at some point in my life. And it never appeared to me that motivational interviewing had anything to do with shared decision-making until I had a conversation with Kristen. And I think there are some congruences there that I think are worth exploring and hopefully can get us out of our respective ghettos to have a different kind of conversation. We were hoping for sort of a Charlie Rose type format where, I'm Charlie. That would be fun. Due to the logistics, I think what we're going to do, I'm just going to introduce our speakers. They are going to do a more traditional PowerPoint talk. We're going to leave plenty of time at the end for group conversation. And so the conversation that we start today, we hope to then expand out to the audience and try to stimulate a conversation about what are the intersections between traditional kind of behavior change theory, motivational interviewing, and sort of the orthodoxies of the field of shared decision-making. So I think that's the goal for now. So allow me to introduce our speakers. So that was an audio quake. Our first speaker is Andrea Cheville, and she is a practicing physical medicine and rehabilitation physician at Mayo Clinic and a palliative care physician, and also does a lot of quality of life and functional outcome research. And she's going to start with a perspective of sort of a frustrated clinician trying to work with patients on behavior change problems. And then we'll follow that with Kristen Vickers-Douglas, who will bring the perspective of a therapist and a detailed explanation of motivational interviewing, and bring that in the context of her clinical practice as a clinical psychologist in a primary care setting, where she does a lot of patient education and a lot of counseling about behavior change. And then I will conclude briefly with a set of questions that we won't answer, but hopefully you will help us answer, if that's okay. So we'll start with Andrea.
Well, it's a real pleasure to be here, and I kind of beg your indulgence. I'm not an SDM specialist. In fact, this is really my first interface with SDM at all. What I am is a very ardent proponent of functional preservation across chronic disease. And many of the determinants of whether our patients remain functional, irrespective of the disease, is adherence and their behaviors. And what I'm hoping out of this morning is perhaps we can establish, as John was saying, a dialogue, some recognition of potential constructive overlap to move us forward out of what I would say is a current impasse. So that my talk is very simple. 3 points. 1, health behaviors are absolutely critical determinants of clinical outcomes. And you can break those down simplistically into healthy lifestyle, so cessation of harmful behaviors, i.e. excessive alcohol consumption, tobacco use, adopting positive behaviors, physical activity, and adherence. And where you draw the line between those, it's really more of a continuum. Point 2, current clinical behavior modification strategies are limitedly effective, and I would argue a profound source of clinician frustration. And last, extending SDM to behavioral change may offer us a win-win opportunity, win-win for frustrated clinicians and win-win for the SDM community that, from what I've gleaned over the past 3 days, is really looking for inroads, for greater penetrance and uptake. So first, health behaviors are critical determinants of clinical outcomes. And this is a laundry list of all that you almost cannot name a condition that we routinely treat that is not significantly impacted by health behaviors. And the biggies that have really been implicated in increasing healthcare utilization: type 2 diabetes, high blood pressure, congestive heart failure, osteoarthritis, all profoundly determined by our patients' behaviors, both in terms of primary and secondary prevention. This is a histogram from the U.S. We're very concerned with obesity. Obesity, as you see here, has been implicated more than any other behaviorally determined condition in increasing patients' risk of chronic conditions. So essentially almost a 70% increase in the risk of developing a chronic, lifelong adverse health condition if you are obese. That's comparable to aging 20 years, more potent than living in poverty. And then you can see on the left-hand side, being a current smoker, a roughly 25 to 30% increase, a heavy drinker, 15% increase, and a past smoker. So all of these very much play on who develops a chronic condition and what happens, its virulence, its impact on their functionality, their life once they develop it. This is a histogram from a report generated by the Robert Wood Johnson Foundation illustrating the increase in prevalence of multimorbidity. This is unique to the United States, but having reviewed the literature recently, it's ubiquitous across the developed world. We are confronting, not with the silver tsunami, the shifting in demographics, aging of the population, but with other factors, a radically increased prevalence of multimorbidity, patients with multiple severe medical conditions, most of which are behaviorally determined. And what does this do? It engenders polypharmacy with all of its well-documented ills. It creates complex management needs. Each condition comes with its drugs, its behavioral change, and they are additive. They synergize. The confluence of chronic conditions synergize in degrading function. In fact, if you have 2 chronic conditions in lieu of 1, you're almost 300 times more likely to have an activity limitation. They contribute to pain and psychiatric morbidity. And these are the 3 critical determinants of quality of life. If you look at those of you who are familiar with utilities, look at the 5 dimensions of the EQ5D. 3 of them are functional, 1 is pain, or discomfort, and the last is psychiatric morbidity. So these are really, I would argue, our critical targets as healthcare providers that we are trying to ameliorate in our patients. All chronic conditions are positively impacted by healthy lifestyles, profoundly so. And adherence. Obviously, adherence to recommended treatments make a huge difference. Well-documented high adherence significantly improves health outcomes and reduces the annual cost for secondary prevention. There isn't a chronic disease where you won't find a very robust evidence base. Unfortunately, adherence rates, and this is for medication, this is taking a pill once or twice a day, adherence rates are routinely reported to be less than 50%. So when you start to extrapolate that to more complex behavioral change, they're far lower. And the hard truth is our patients really don't want to change. This is directly taken from a commentary, an editorial in the Journal of the American Medical Association by Alan Detsky. I'll read verbatim. Medications and surgery. Patients prefer treatments that they perceive will require little effort on their part. Medications and surgical procedures are preferred over clinical strategies that involve behavioral change, i.e. or e.g. diet, smoking cessation, or exercise regimen. We're humans. We want quick fixes for the most part. And yet, if we care, if we are, I would argue, are competent clinicians, an integral part of our role is constructive behavioral change in our patients. And unfortunately, current behavioral modification strategies are truly limitedly effective, and they frustrate clinicians. And we can divide these into those that occur at the bedside or in the clinic, from the more sophisticated, involved behavioral change strategies that play out in our integrated programs for the cessation of unhealthy behaviors, e.g. smoking, alcoholism treatment, dietary programs. Those are, I would argue, quite separate from what goes on, the ongoing dialogue, daily routine dialogue at the clinic, which is not informed and is, I would argue, a great source of frustration for clinicians. We are limitedly able to impact behaviors, both from a primary preventative and secondary preventative standpoint. This is well documented. Often we are approached for quick fixes. And many times patients resent it when we mention behavioral change. I was sharing an anecdote with Kristen before the program. One of our very well-known, very respected breast cancer physicians at the Mayo Clinic found that after treating her patients, they would continue to come back for years for survivorship care. There's a real bond, I think, that develops when a patient goes through an experience like breast cancer. The downside to this is that displaces the space of it, clinical space for new visits. And so what Lynn would do when she felt like a patient really was out of the woods and safe would say, well, you know, you're doing so very well from a breast cancer perspective. I think we should broaden our focus. Let's address your lifestyle and see if we can get you even better. How about weight reduction? And very quickly the patient would stop coming back to clinic. And I have found that to be true in my experience. You can almost feel the temperature in the room go down when you broach dietary restraint. And yet, we are asked as clinicians to manage the long-term consequences of non-adherence, of sustained unhealthy lifestyle choices. So I want to share with you a bit about lymphedema. This is one of my specialty areas. I direct the lymphedema program at Mayo. I previously directed the lymphedema program at the University of Pennsylvania. And it's a horrible condition. Peter Ubel set me up a little bit last night talking about his wife's experience and her risk of lymphedema after axillary lymphadenectomy. Lymphedema is incurable. We see a dramatically increasing prevalence now because of the obesity pandemic in the United States. We can control it, and this is the slide you saw previously, that's not uncommon. To see limbs of that size, that volume, is certainly not uncommon in our clinical experience. We can control it. How do we do that? Very arduously, through a combined multimodal program of wrapping, massage, exercise, and skincare. And this just gives you an example of how involved the wrapping is. We use a stockinette and an under kind of cotton batting to distribute pressure. We use foam, and then bandages. We will put as many as 30 bandages on a leg in an effort to reduce it. And why do we do that? Because we can take legs like these, this is one of my first patients, and make them look like this. We can virtually reverse the volumetric changes. However, to sustain that reduction, it requires ongoing, unwavering adherence by the patient, which is not easy. They have to wear garments during the day, modeled by women that certainly do not have lymphedema. These are hot. They don't look particularly nice. They're awful in the summertime when lymphedema tends to get worse. Patients have to either wrap at night, you saw the bandaging, every night, or wear these bulky, uncomfortable, and hot devices at night. And if they don't, they will revert quite quickly to their status prior to the initiation of treatment. We do not have a drug for lymphedema, despite a lot of efforts to find one. It's a testimony to how difficult the behaviors, the maintenance behaviors are, that now we're seeing lymph node transplant being offered to patient. The evidence base is appalling. There is no evidence that lymph node transplantation works. We do know that it can engender lymphedema in the area, the body part drained by the removed lymph node, and yet patients are flocking to undergo this surgery. I've been doing this about 15 years, and I've never had a patient that adhered perfectly. And so what we wind up doing is a back and forth. We reduce them, which is quite arduous on the part of the therapist. Over 6 months to 12 months, they recur, we reduce them, and so it's kind of this ping-ponging. One thing, I think, a message that has come to clinicians, when behavior change fails or adherence fails, it's not the patient. The problem is the system. You need to create a system that is conducive and will enable the patient to succeed. So that places an unwelcome onus on a clinician. Most of us aren't even sure what the system is or how to start to address it in 20 minutes of our clinical visits. So I think a lot of us feel limitedly able to influence the primary determinant, i.e. behavior, of our therapeutic activities. And unlike in the hospital, when we have a great deal of control, once patients leave our offices, we have no control over what they do. It's a little bit like parenting. And I think we fall back on a lot of the behaviors, the default behaviors that we adopt as parents. Nobody trains clinicians. Very few, I would argue, clinicians come to their encounters with any type of constructive, informed background in behavioral change. So what do? We educate. We're logical. We're armed with a great deal of information. We try and teach our patients. Carrots, rewards. We praise them. We barter in terms of continuation of a therapeutic relationship. I will remain devoted in your well-being if you adhere to the things I'm recommending. And we barter in goods. We barter in prescriptions. And we use sticks. We criticize patients for non-adherence. There's sometimes a threat of discontinuation of a therapeutic relationship for non-adherent patients. We can withhold prescriptions and use what I would describe as the assault of the truth. For most patients with lymphedema, if you show them the unhealing wounds, the recurrent cellulitis, the gross dysmorphism that can happen, it is bludgeoning them with a truth that the clinician holds, and this is true of many diseases, it doesn't feel good, and it is manipulative. It's threatening, and it feels a bit like bullying. And yet we do these things because we care and because we don't have other constructive tools to encourage behavior change. And just like a child, how many of you are parents and barter with your kids and thought you'd never be doing that? We barter in clinical encounter. These are examples from my own experience. Opioids for physical therapy attendance. I have a patient who just wants me to give her oxycodone. She doesn't want to go to her PT visits that would really help the root problem, and so we barter. Diuretics for enrollment in a weight reduction program. I have a lot of my lymphedema patients. Diuretics are not indicated, but they want them. I want them to lose weight, and so we barter. An example, a patient of mine wants a letter of medical necessity so that her insurance company will pay for massage. I want her to adhere to her home exercise program so she won't need the massage. We barter. I have another patient who I've been trying to get into stress management for a very long time. She calls the afternoon before a full clinic in crisis demanding to get on my schedule. And so I do so, but again, I barter. I want her to get into stress reduction. And I would argue there are adverse consequences. I don't have a lot of citations because I really haven't seen this written about a great deal. But I think these default approaches to influencing patients' behaviors can be profoundly erosive to the therapeutic relationship. They induce frustration on both parts, the clinician and the patient. Resentment. We're not dispassionate. We're very invested, frankly, in the advice that we give, and we're not dispassionate about whether patients take it to heart and adhere. And I think we judge our patients. In some ways, a lot of obesity, for one, is an inability to delay gratification for some patients. I don't claim to be an expert. And I think we do judge. And yet, relationship with our patients is, I think, what most clinicians strive for, what keeps us in the business, and is the most powerful antidote to burnout, which is highly prevalent. Rates suggest over 50% of physicians are burned out. So could we extend SDM, and this is purely hypothetical, to behavioral change, bringing MI possibly as a mediating force to create a win-win opportunity? Because clinicians need help. We're at a frustrated impasse, and again, limitedly able to induce constructive behavioral change, and SDM needs clinical uptake. I was impressed as I was attending yesterday the presentation on the Cochrane Review, and very explicitly from the outset, lifestyle and adherence were disincluded from the literature included in the Cochrane Review. And yet, those reflect cumulative daily small decisions that bring patients to the point of the major decisions that seems to be the focus of SDM. And if patients are to be empowered, and this is really what SDM is about, if we are to move away from clinical paternalism, I would argue that patients need to be aware of and own the consequences of their small daily decisions. I think this needs to be made more explicit in the clinical encounter. So could SDM and MI help clinicians out of this frustrating impasse? I think one aspect is reframing success. We very much come with this idea of getting to yes. I have a fixed idea of adherence, and success is making my patient adhere the way I conceptualize it, or stop smoking, or enter a diet weight reduction program. Are there opportunities to reframe success? Perhaps it's just knowing that our patient understands the consequences and is volitionally continuing on a course. I have done my duty. Could risk information be provided as it is in a decision aid, but about behavioral choices, so that it doesn't feel like bullying or bludgeoning patients with the assault of the truth? How can we leverage MI and SDM in a way that helps both clinicians and patients move toward the frank, constructive, and mutually respectful communication that I think we all desperately desire. So with that, I will turn the mic over to Kristen.
Okay, I'm going to have a pop quiz while Kristen gets her slides up. Raise your hand in response. Who would say that it's appropriate to use shared decision making to promote smoking cessation? Raise your hand. Okay, about half or 2/3 of the crowd. Okay, good. We'll see why that's relevant in a little bit.
Is it possible to bring up the lights? May we? Yeah. Thank you. Great. Good morning, everyone. Hi, I'm Kristen Vickers Douglas. You want to take a moment, just introduce yourself to your neighbor, say good morning? How many of you have some experience with motivational interviewing? Can I see hands? Good. How many of you would say that you use it every day? Great. All right, so we've got a lot of expertise right here in the room. And I really want to just make this a conversation about how MI and communication with patients is a way to think about conversations and the frustrations and challenges that we've heard so far. So many of you know the history of motivational interviewing, but for those who don't, it really came out of this culture of addictions. And Bill Miller, who I've had the privilege of spending some time with, talks about the culture of confrontation that was really prevalent in the 80s in addictions treatment. Does anyone work in addictions or have a history in addictions? Nobody? Okay. And so what my colleagues at Mayo will talk about is you would just feel that it was appropriate to go after your patients because they were in denial and they were doing bad things. And so for their own good, you'd call them on it and you'd talk to them about it and you'd confront them with the facts. Confrontation of the truth, is that what you called it? Assault, that's a good word, assault of the truth. And so out of research that Dr. Miller was doing, they recognized that clinicians who were supposed to be doing the exact same protocol for problem drinkers were having different outcomes. And that those clinicians who were rolling with the resistance and rolling with the problems rather than confronting and bullying were actually having the problem drinkers come back after a relapse and continue on. And from that observation began a whole bunch of wonderful research and scholarship and clinical development in how to talk to patients when they're struggling. And this dynamic of I push you, you push back, I tell you you got to change and I know what's best for you, and you say, well, no, you don't know a thing about me. And the temperature changes in the room, and we both suffer, and this negativity. And it's not even a conversation about how we're really feeling and how frustrated we are. You heard from Andrea all of the emotions of the clinician, and of course the patient is not happy to be there either. One great study, I do qualitative research, and one great study of patients with chronic conditions, with heart failure, I believe, they were asking, what's the relationship like with going in to have a conversation about chronic care with your physician? And spontaneously, multiple patients compared that relationship and conversation with going into a very specific person's office, going into the blank's office. Can you guess? Whose office? The principal's office, yes. So the boss of this elementary school. And the idea is that you will be in trouble. You're going to be scolded, that you have to go in. One patient says, I want to go in, take my licks, and get out of there. So these conversations, you're not looking forward to them as a clinician. The patient isn't looking forward to them if they're this push and push back. Motivational interviewing, I'll talk a little bit more about what it is, a definition briefly. But is it effective? the time that they started to write about it and look at different ways of having conversations, we now have motivational interviewing move from addictions and counselors delivering it, but into the healthcare system, even brief encounters. And enough science has accumulated. We have meta-analyses and really showing that it is effective. Some of the challenges, though, is measuring, are the clinicians actually doing motivational interviewing? You know, it's something that people talk about, sometimes without a real sense of what it is. And I find I do a lot of training of nurses and health coaches, therapists, and you say MI, some people get really nervous. It feels like it's going to be something completely outside of their skill set, their comfort zone, that it's going to be really hard and they don't really want to do it. And others will just buy in so completely that they say that they're doing, and they're not, you know, if you look at it and listen to their recordings, because they believe so much in it, they believe they're doing it. And so I hate to say that we have to code every single conversation and get really nitpicky of all the jargon of motivational interviewing. So I wanted to just kind of boil it down this morning to say, well, what are some of the main points when people say motivational interviewing? What's it all about? Because even Bill Miller and Steve Rolnick will say that, there's a lot that motivational interviewing is. There's just the basics of good communication and the art of healing, talking to one another, listening. So much in common with Rogerian psychotherapy, for instance. So they aren't banging a drum saying this is the only thing, a special, unique thing. There's some aspects of it that are unique and are seeming to drive the treatment effects. But people have, I think, an emotional reaction even to what it is, and does it fit with their identity as a clinician? Can they do it? Well, what is it? What's it for? So the idea of motivational interviewing, first and foremost, it's a conversation. So, interview makes it sound like one person is asking questions and the other person is coughing up information. And that really doesn't, it seems like an unfortunate name in some ways, because this conversation is just continuous looping of information and feelings and beliefs that are shared. Importantly, it addresses the issue of people being ambivalent, stuck. I don't want my legs to look like that, but I don't want to wear those wraps. And so the idea that it isn't just non-adherent, bad patients that are ambivalent about behavior change, but all of us. And so it's a common problem, and I think MI and the writing around it helped us realize that ambivalence is just, it's there for healthy people, for all of us. What I particularly like about motivational interviewing is the attention that we place, how we listen for the language of change. As clinicians, we are helpers, do-gooders, fixers, resource people, educators, and so when we're listening to problems, we're thinking about what? Hear a problem, think about a solution, a fix. And the longer you've been in practice, the more passionate you are about your work. You're just chock full of information, advice, and recommendations. So I believe it makes us think differently, listen to different things in the conversation. So what we pay attention to includes the language of change, how the patient describes their abilities, their values, what they care about. It's meant to strengthen personal motivation, and not just in general in a vague way. It's meant to strengthen motivation to make a specific behavior change. And that's one of the myths about it, I think. Clinicians will sometimes feel like, when I'm describing it, that it's meant to be kind of just a warm, fuzzy approach to keeping a patient company until they decide to change on their own. But it is a directive approach. And so when we think about motivational interviewing, it's compared to, instead of a wrestling match where you're trying to take down the patient and convince them to change with manipulation or overpower them, it's a dance. And in this dance, you as the clinician are in the lead. A lot of people think, well, it must be the patient-centered care. The patient must be in the lead of the dance. It's a collaboration, but we as clinicians guide the conversation, and our efforts to select and be strategic about what we are inviting the patient to really share and to guide the conversation helps move it forward in the direction of change. It's collaborative. It honors autonomy, including a patient's right to go home and not do any of the things that we talked about. And then it's our job to sit with that and suffer with it and make that as healthy of a response as we can have so it doesn't come back into the reactions of confrontation. It's evocative, meaning it's pulling and pulling and pulling. And sometimes I think people think they're being very evocative when they just ask a whole bunch of data questions. And that is, with the coaches and the nurses that I work with, I talk about that's sometimes the place we hide as clinicians. This is uncomfortable. I don't like this conversation. I'm just going to ask a whole bunch of questions. Get a lot of history. Get a lot of facts. How about this? How about this? So although open-ended questions and pulling from the patient are part of MI, it's what you pull. The spirit of MI, I think, really has a lot in common of the spirit of what we think of with shared decision-making and conversations about patient choice and informing them to move forward with their health. And Bill Miller talks about there are people who say that they're doing MI, and he listens to them, and it feels like a used car salesman. And that was before he had compassion in the model. He thought that was just obvious in there. But if you're just making a deal, negotiating a plan, it's important that it is in the spirit of this compassion. But acceptance, I think, is a hard one for us as clinicians. This includes acceptance of bad outcomes, acceptance of a patient being stuck and not choosing to do anything. And that doesn't mean that we give up. It's how do we kind of ride the wave of that. How do I think that it's compatible? And I think this, we really want to have conversation about this together. But I believe that the emphasis on choice and autonomy really fits, that it's collaborative, that we want patients to engage in healthier behavior after they make choice about what to do. And the patient is viewed as expert also, bringing the values, preferences, their experiences, their resources to bear in the conversation. What gets hard about it? Rule is just an easy way to remember some of the key principles, but this resisting the writing reflex, especially when we are hearing problems. I, as a clinical psychologist, work a lot with patients who have health behavior problems and emotional health comorbidities, like depression. And for people with depression, they're less optimistic that they'll be successful, they're less likely to try, and certainly when you meet back with them to hear how it's gone, the first thing you hear are the problems and the frustrations, and they're very hard on themselves. They're more likely to have problems with weight. They're more likely to smoke. And so high use of problem behaviors even to cope with their emotional health. So for instance, a study of mine, exercise intervention for depressed women who smoke. So I work with kind of the big old mess that many of you do. And when you are hearing someone talk about the problems that they ran into, the barriers, it is so easy to fall into the fix-it trap and say, you could do this, you could do this, you could do this. And as you push that, they push back with the reasons why not. People believe what they hear themselves say. If in the conversation with you, what they leave that encounter saying, yes, but I can't. Yes, but that won't work. Yes, but I tried that. You don't understand. That costs too much money. That doesn't work. My body works differently than that. The more that they are basically underlining this position and digging into, they're arguing against change. And there's so many of these conversations that are happening that we mean for them to be forward-moving and helpful, and yet we're creating this space for a patient to talk themselves out of change. And this writing reflex, and this is the one that my, especially nurse colleagues, struggle the most with because they have so much great information and desire to help. But these conversations go to, yes, and you know what you could try? I've got another resource for you. And then we move into this. And the pushback, by the way, isn't always verbal. The pushback isn't always that the patient is saying, no, I won't, or I can't. It can also be just, they become passive, they become quiet, they do nothing. listening, engaging, empowering, and working to really understand their ambivalence. The newest book on motivational interviewing talks about a process of motivational interviewing that starts with engagement. So oftentimes when we are so short on time in clinical encounters, we go right to the plan. What are we going to do? What are the next steps? What's the goal? And so really this process of first you shore up the therapeutic relationship by trying to understand that patient, including their ambivalence, including all the good reasons to have bad behaviors, focusing in, coming to agreement about what we're even talking about for a behavior, pulling from them what they know. And we've heard some about the ask, tell, ask, or elicit, provide, elicit framework. Pull first, what do they know? What do they care about? What do they wish to do? And then making the plan only then. You know, just foundational skills of OARS. You think about, you're in a conversation with a patient in your clinical encounter. You want it to go forward toward behavior change and better health. Imagine you're in a little boat, and the OARS is what will move the conversation forward. And OARS stands for open-ended questions, affirmations, reflections, and summaries, and it looks so simple. And it looks like this is what we know and this is what we do. Always when you feel that the conversation isn't going forward, then we come back to say, what can I use of these just basic, fundamental communication strategies? And again, open-ended questions can be the place that we hide. I really work, especially when I'm feeling frustrated and I'm aware that this patient is relapsing or they're arguing against change vigorously. I will set my intentions in an encounter, even a brief one, and I'll say, you know, for the next 3 minutes, 5 minutes, I'm going to listen with just the intent to try and find something to affirm. Now, an affirmation is more than just a good job. You did it, that's great. And when I listen to recordings of encounters and when I'm doing training, I will find that clinicians have a good sense of when to jump in and offer praise and encouragement. But oftentimes it's a very superficial comment, like, oh, that sounds good. You really did it. That's great. Awesome. We talk about it's important to coach the person, not the behavior. And a lot of times conversations about behavior change end up being conversations about how many minutes of physical activity, what days of the week, what about the morning, how about during the lunch. Just these little snippets of boring data points that maybe eventually will be very important to sort out, but it's not about a person's life, it's not about what they care about, it's not the motivating facts that will move them forward. And that's why starting with planning doesn't rev people up toward change very much. Affirmations require us to listen for something that's an authentic quality or skill or ability for someone. And instead of listening for the problem areas and the barriers, to intentionally listen to say, what is going right within all that is going wrong? What did she do even to get herself to this appointment today? What are the things that I can try and then dig a little bit more about? So instead of asking more about how many days a week is she going to follow through on this plan, how is it that she got herself here? How is it that she succeeded in the past? And to really guide conversations so that people hear themselves say, I have the skills, abilities to do this. And that's where Change Talk really expands upon that. Listening intentionally to people's desires, abilities, reasons, and needs for change. Do I have time? Can we try this real quick?
Sure.
So I'm going to be Carla. And just to give you a little chance to interact here, when you hear Change Talk, I want you to raise your hand and say, there. Okay, so this is, I'm going to just kind of have a little dialogue here, or it'll be a monologue. I'll just talk. When you hear Change Talk, so if she utters in all that is wrong, if she says, but I have a reason that I want to, or the status quo is not sustainable, I need to do something else. Or even stronger Change Talk would be, I'm going to, I plan to, I've already started. When you hear it, say there. Say it loud. So I'm Carla, and I am the cook at the Assisted Living Center just right down the block. So this is an elder care place. The residents are like family. I love them. I'm a single woman, and going to work is a joy for me. Cook is a very popular role at assisted living because I make all this great comfort food, nourishing food, and a lot of the structure of our day for the residents is about when we're going to eat, how long till lunch. It's a time we all come together. I work in an industrial kitchen, and so I have to, use all the stuff that they have there. But I'm a creative person in the kitchen. I've got some real skills to kind of tweak recipes. And I know I'm going to have to talk about that because I have my endocrinology visit tomorrow. I have type 2 diabetes, and so does my mom. She's on insulin, and I'm heading right that way. My endocrinologist, who's super sweet, I really, really like him, but he's going to holler at me tomorrow because I definitely have been gaining weight over the holidays. Oh, I have some new recipes that for these cakes with buttercream frosting, they are a hit. And there's always a birthday, there's always an anniversary. I have some buddies that are nurses, and in the afternoon when it gets quiet and the residents are sleeping, we gather and we kind of nibble on leftovers and chit-chat, and that's our social time, and that's our time to be there. And these cakes, oh, they are good, and we have been spending some time visiting, and that's my social time, like I said. So I don't want to go on insulin. I definitely don't want to have that for my future. And I have to tell you too, my best friend at work, Linda, she put on 20 pounds over the holidays, and she blames me for it, and I feel bad for that. I don't want to take her down with me. I'm worried about my health. I don't want to go in tomorrow and get hollered at, like I said, but it's nobody's fault but mine. I mean, I'm making this stuff. It's hard to think about making, I went to see a dietitian once. She said I should have veggie trays for our snacks in the afternoon, and I didn't go back because if I brought out veggie trays to my nurses, and there'd be a riot. People would hate that. So I don't know, because I'm stuck with the recipes at this industrial kitchen. I eat almost all my meals there. And I could probably make some changes just for me, but I like to eat in a group with people. I like to eat with others. When I'm home, I'm alone. I want to be with people, and what they like is my cake. Okay, so you heard Carla talking about barriers and problems, but the theirs are these opportunities in a conversation to learn more about her desires, her abilities. Usually in conversations, we just naturally follow the last thing that somebody says. The last thing she says is, but they like cakes. Oh, well, the fix-it in me, reflex would say, well, what could you have that's a healthier alternative besides cakes? And that's how these conversations happen. That's a problem. I'll fix the most recent problem. In motivational interviewing, what we do would we jump back to any of those theirs that you said and ask, tell me more about that. What would you want to have happen? How is it that you got that way? Ask how did you get so creative in the kitchen? What are your strengths in this area? And inviting elaboration. And then we use the ORs, open-ended questions, reflections to keep going with it. And when you think about where this could fit in a decision conversation, say yes if you think that listening intentionally for what the patient can bring toward change and inviting the conversation to stay there rather than jumping to the plan and the fix and the goal. Could this kind of stuff happen before a decision aid is introduced? Is some of that foundational stuff? Maybe yes. Maybe during the conversation itself. Maybe after the decision is made and they're trying to figure out what they do for the change. And at follow-up when they're talking about how it went. And I think that all of it, all those places, it's a way of listening differently and responding to and guiding conversations in a different order that doesn't just mean that we fix it. There's a great article, Rolnick and Miller, about just questions that would help the conversation go to these. So I'll leave those up, and there's great resources for this. But we wanted to talk about just kind of a little bit about what MI is, and that's the background, and now how this all melds together. So I'll come back over to the table.
I think flanking is fine. Well, let's thank Kristen and Andrea for those very stimulating presentations. Now it officially feels like a talk show, and it's going to get more like that because there will be folks in the back with microphones, yes, walking around. But I would just like, as the moderator, to offer a few questions for general contemplation here while you get your creative question juices flowing. I think an overarching question here is, where does motivational interviewing and some, what I would say, sort of patient-centered behavior change models, how do those fit with our conceptualization of shared decision-making? And I think a couple of areas that have stimulated my thinking in this area is Jenny Blumenthal-Barbie's recent Health Affairs article on asking the question whether shared decision-making could be directive or use some degree of paternalism in terms of how it structured choices. I think the quiz item that I asked you before suggests that there might be some wiggle room in terms of overlap between behavior change domains and shared decision-making. I think if we were applying the orthodoxy of shared decision-making to only so-called preference-sensitive decision where the evidence is ambiguous, we would not use shared decision-making for smoking cessation. Or if we did, it would be merely to ask the patient when they want to stop smoking, not if they want to stop smoking. So I think that we've gone from, hopefully, illustrated how these seemingly sort of separate parallel ghettos, so to speak, in terms of the clinical interaction are actually sort of, there's a lot of back alleys between those ghettos, so to speak. I also think, I'd be curious what the crowd thinks. I wonder if there are blind spots in the literature and the thinking about shared decision-making that motivational interviewing may expose. One area that I was thinking about is to what extent does the shared decision-making world talk a lot about clinician emotion and the role that clinician emotion may play positively or negatively in the clinical relationship. And then are the outcomes that we're using in, say, our standard decision aid trials congruent with or discordant with, in some ways, the mentality and the psyche of a empathic behavior change conceptualization of the clinical relationship that motivational interviewing seems to bring. So those are questions, not answers. If you have answers, definitely please raise your hand. If you have more questions for either for the panelists or for other members of the audience, also please chime in.
Is the microphone coming?
Thanks. I'm not sure that this is an answer, but it's perhaps a slightly different way of looking at it. I and some colleagues are just doing a Cochrane review of what we call personalised care planning. And we've seen shared decision-making coming in at several levels. So, for example, rather than starting with the clinician starting with the idea that the most important thing for this person to do is to stop smoking, I mean, even that starting point, the shared decision-making bit could be, what kind of support do you need to help you stop smoking? So, and there are obviously there's a whole range of options. So it fits there. But the way we're thinking about it is going one step back and saying, so the issue is, how can we help you to manage your diabetes? Now, in managing your diabetes, there may be a whole number of things you need to do. That might help. So stopping smoking might be one, taking more exercise might be another, changing your diet, etc., etc., and indeed taking medications and so on. So that the shared decision-making bit, if you kind of unpack that whole process of self-management support, and you start with sort of agenda setting and then goal setting and action planning and go round that cycle. Shared decision-making might come in at all those points, but in particular, it's going to come in at the care planning, the sort of goal-setting, action planning bit. And then it seems to me that a shared decision-making approach would insist that, if the patient says, look, smoking is something I just cannot tackle now, but, I might be able to make some changes to my diet or whatever it is, then you follow that. You don't bang on about the smoking. because you let the patient set the agenda. Does that make sense?
I have a question in that office visits are getting shorter and patients are getting older and more complicated. And so anything I think that is really going to have broad practical uptake has to be super simple and has to integrate into clinical encounters without a lot of special training that offers immediate benefit, because otherwise I think the clinicians just won't use it. They'll sit on the shelves. So in terms of promoting and helping to sustain behavioral change, like what might a decision aid look like, or pragmatically, how would that occur in the clinical encounter? And-
This is wonderful. This is an area that I work on as well, and I think that to deliver chronic condition self-management education and support, oftentimes it requires a team of providers rather than a single provider. Do you have nurse care coordinators or someone assisting with these kind of coaching conversations? And these are the people that I work with and find that the menu of options of different self-management behaviors allows this patient choice, and they can move back and forth about where their priorities are to put their energy. But where it goes from they'll say, the nurses will say, I'm trying to have these be collaborative conversations, where the menu of options, self-management plan, I'm using that to guide where we go. And it's when they get to the point of making the plan and narrowing it down to the goal that the dynamic kind of shifts, and it gets more of that fix it. And so you hear, and it's true with the physical therapists I work with and many different, the dietitians, different professionals, when they feel like a goal is about, it's kind of like going fishing, and they feel, oh, we're going to get to the goal. I've got them on the line. We're going to make a goal for physical activity or medication adherence. All of a sudden, it is less collaborative. It's like, let me get down the details of this. And instead of coaching the person in the context of their life, it is this superficial, cold behavior. And what then they miss is that ambivalence can come up at any point. And so maybe someone was selecting a self-management area that they were really thought was the best thing, most important. They've got skills and resources. But when it gets down to the nitty-gritty of it, all of a sudden they're feeling like, maybe I'm going to backpedal a little bit. This isn't what I want to do. And by that time, the clinician, they're so excited because that's our comfort zone, that they're in that action mode, and so then they're pushing. So it's an opportunity to say, there's this building and the processes of MI, and people feel more comfortable with this listening and communication early on when you're building the relationship. But then the more behavioral it gets, the more it seems like people revert back. So just the caution note that the ambivalence can come back up anywhere, and then the conversation just continues. Mm-hmm.
This is Eric Hess. I just had a comment on what, John, you'd mentioned earlier about towards a conceptual model that takes into account some of the overlap of motivational interviewing and shared decision-making. And there's been multiple references and side notes when we talk about shared decision-making that values and preferences may not be stable. And it makes us a little bit uncomfortable because shared decision-making is hard enough in and of itself. Yeah. But perhaps motivational interviewing can kind of maybe lift up the hood on the car to get a sense of what might lead to some of those values and preferences, and give us some insight as to why they may be more or less stable, and maybe that's too simplistic of a conceptual model, but take her to leave it.
I'm just curious whether what folks think about maybe shared decision making and motivational interviewing being two separate strategies toward sort of undoing the excessive paternalism of healthcare providers through different channels, or are these sort of parallel ghetto vocabularies, so to speak, getting in the way? And should we be looking for an umbrella category, perhaps something like personalized care planning, that seems a little less jargony and a little more universal? Is it helpful to have separate vocabularies and have different entry points, sort of like it's sort of like antiretroviral therapy, right? If you attack it from multiple angles, maybe you get at the problem in a more sophisticated way, or do we need to start a language revolt?
I'm worried about the language myself. Just because I do so much of the training, that I think that motivational interviewing, the basics of it are communication strategies that should be universal, and a lot of people believe in when they hear it. And I worry about the language. And one of our earlier presentations about the language that patients use about the decision isn't the word that they like, that next steps is better, that when we talk to physicians and clinicians, maybe there is a more neutral way to describe this, because there's a lot of baggage that comes with MI, even though now there's a lot of research that comes with MI, but a sense that these are therapists who have an hour conversation long-term with patients, and so something that feels, I don't know, I worry about that too. We want to take all that's good about it, but that is a barrier, I think, in the uptake, that it feels like this is something other people do.
One thing that I think is, I keep coming back to pragmatism, but at the end of the day, if some of this, what you talk, this is a process that goes on over a year, and it's a bit abstract, it's an ethos, it's almost a culture, that type of change, I think, is very challenging for broad uptake, particularly when there's a long established to relinquish its hold. Particularly physicians have historically had a lot of power, economic and societal power, and in many ways this challenges that. That said, I think everybody recognizes it. Certainly the literature is replete with the ills of non-adherence and unhealthy lifestyles. We're paying a lot of money. The entire developed world is paying, negotiating spiraling healthcare costs. But I think at some level, most clinicians are not going to, I don't think, maybe I'm wrong, I hope I'm wrong, but I don't think they're going to learn MI. I don't think they're going to take the time to really learn the kind of the nuanced SDM process that you allude to. And so at the end of the day, if we really want to make a change, if we really want to improve the situation, they're going to have to be pithy, quick, take-home, pragmatic strategies. I mean, I was at Harvard for my medical school, and we had a patient-doctor course, and it was about second year better communication with patients. And one of the it was actually a musical number in our second year show, which was a parody called "This Must Be Hard for You." That was the refrain that we were instructed to rely on to communicate our compassion. And for all of the how silly it felt, if I didn't find myself uttering that at the bedside often, because you don't have these skills. You can have the best intention in the world, but many times, particularly when emotions are running high, whether it's frustration or ambivalence, you need to have fallback strategies that don't take a lot of integrative thought. Okay, what would this wonderful ethos of SDM look like in this complex and emotionally charged encounter? So I would throw out to the audience, what are some very pragmatic, simple things that clinicians could use to bring that ethos more palpably into their encounters?
And just with the note too, that if you if you script it, you kill it when it comes to motivational interviewing too. So that's the other challenge, because can you build in, here's the right response. The more that there's an algorithm and you script an encounter, the less likely that the intervention has succeeded from the motivational interviewing standpoint. So how do you bridge these two things? Make it quick, make it the right thing, but don't script it.
Glenn?
Thanks for this conversation. It's clearly challenging, especially when you've got short interactions. But usually in primary care, where you've got short interactions, you've got multiple longitudinal interactions, and people come back. And that's the key here, I think, when you're trying to build a constructive relationship for behavior change. And some people have worried about motivational interviewing, equipped to say this is manipulative interviewing because you're trying to change somebody's behavior. I don't believe that's the case. I think you're trying to work with people's motivations and trying to find their own motivations, and that usually is a process rather than an episode. So that's very important to recognize, I think, that these cannot really work in 10-minute episodes, that they are ongoing therapeutic relationships that are built over time, which is why I think motivational interviewing doesn't really fit into one-off secondary care encounters. Very hard to do it there, although you do elements of it perhaps. But the main point I wanted to make, I guess, is that I'm trying to work with Stephen Olnick, who's my colleague in Cardiff, around this very issue, and trying to see how you can actually, and I know the jargon, the language gets in the way sometimes, but that practitioners need to be able to flip between a change language and a choice language, which is essentially the element here. Trying to find where there's a motivational piece that you need to build into to say, this is about change, and can we find your own motivations for that issue? But then flipping back to choice language and say, in this situation, there are a few things that are possible. Let's just list those options, explore what might be the benefits and potential downsides of those options, and then revert back quite quickly to change language to say, what of these issues appeal to you? And I think this issue of using a change vocabulary or a choice vocabulary is not something that's alien to practitioners. They do it all the day in their family lives. Why would they not find it easy to do this in their consultations with patients? So I think the issue here is about simplifying the concepts, but saying one's about change and helping people find their own motivations. One's about laying out choices and exploring those with the client in front of you. And I don't think that's enormously difficult. And I want to refer back to Peter Ubel's keynote, really, is that if practitioners don't know how to do this, they shouldn't be in practice.
Thanks. I think there's a couple hands here. Yeah, good. Okay, and then, good. Can you just,
My name is Ingrid Nota from the Netherlands, and well, during this conference we are talking a lot about change and changing the culture. Maybe we need some elements of motivational interviewing to implement SDM. Maybe clinicians need to, well, we need motivational interviewing to change the clinicians. I don't know.
That's great. You're sort of taking going meta with the question,
Yes.
and maybe we have the wrong. The object of motivational interviewing should be changed to clinicians, right?
Yeah, maybe.
Well, and if you think about the processes, too, of motivational interviewing, it starts with engagement rather than the action plan. So if we start with an implementation plan, you do this, and this is how, and this is instruction and advice, that's the fix-it reflex, right? And so if we go back to working to understand the ambivalence of the clinician and understand the barriers from their perspective and show that we heard that, build the engagement, and then collaborate. So I agree. Yeah, wonderful insight.
I totally agree with those comments about implementation. That's what we try and do, is a participatory approach when we go into the clinics to sell them shared decision making. And I'm curious about lapsing, how to prepare people for a lapse without being negative. But it's something very real, and shared decision making doesn't seem to address for what happens. You've made this decision, but we know it's going to go wrong. We need to prepare everybody that that's okay.
I agree, and the providers too, because the providers will often have a emotional reaction of disappointment and exhaustion, and here we go again. And again, back from addictions, the abstinence violation effect, the idea that once someone has achieved sustained abstinence, when they have a lapse, there's this very emotional reaction of guilt and shame, and then the sense that I have to start all over again. And so conversations, when we have action plans, for instance, in coaching and self-management education, when the goal is set, we really talk about the goal is an experiment. The experiment we should approach with curiosity. It's data. We're going to learn in a context what happens, because I think the goal setting gets, as you've heard me say, very superficial, very behavioral, and the idea is it's just linear. Okay, I've got my goal, now I just do it, and I keep doing it. But if we think about a series of experiments where patients are bringing back information and observations, and then we continually refine in an ongoing process, then even failed experiments bring back very valuable data about barriers we didn't anticipate. And so oftentimes the goal is the last thing in an encounter. Everyone feels good, pack it up, it's done, and then we expect success next time. And so how we frame that conversation about here's the next action steps that you're willing to try, and let's see what happens. And then I think that really reduces this guilt and shame that we have to be perfectly adherent to something that might be the wrong approach. And that creates more time for that conversation. And that's where sometimes there's pushback, because there's something very satisfying about a goal sheet that has one goal on it. Maybe they rate their confidence and it's high, and then the work is done. Goal setting and goal work is a process. So that conversation, I agree, really helps the provider hear themselves say, this could go lots of different ways, and the patient hears themselves say, this could go lots of different ways. The path should be different.
Yeah, and for providers too, though, that burnout is around them not being reinforced. When things go wrong, they give up because they're burnt out, it doesn't seem to be working, and no one's saying you did a good job and you tried. And if we can just, retrain the people who left, or bring in the reinforcements you need to keep going, rather than have it all just sort of fizzle, which is what happens with so many implementations.
One thing I've found, I think that the comment on these are long-term processes that evolve over ideally years. And I think when I've successfully changed a behavior, it's not because of MI, which I'm not very good at. It's because I've established a relationship with a patient, and I've gone to bat for them, and they know I have their back. And relationships are nuanced, they're complex. And I think one of the most powerful things we can do is to accept and forgive. And particularly when patients come to an encounter expecting condemnation and censure because they've fallen back, because their legs gotten big, because whatever. And we're accepting. It creates space. Suddenly it creates space and depth in the relationship. And I think that's, at least for my anecdotal N of one, experience, has been then moving forward. It's nothing. So how often is it a clear linear, upward progression? Our lives are complex, and so I think one of the things, because in rehab we do predominantly behavioral change, but therapeutic exercise is our drug. We write prescriptions, yes, but most of what we do is we try and change behavior. And so I think, again, acceptance, long-term relationship, but that I think is becoming more challenging. with the current demands of healthcare, the economic constraints that we're all increasingly struggling with.
Andrea, that sounds like MI. I mean, you talked about the spirit. She talked about compassion. She talked about acceptance and relationship. And that's why the fact that she said, I don't do MI or it wasn't MI, this is part of that problem, because I think foundationally what you were doing is probably the most important things that got you to it. And you weren't manipulating and bullying. It was, but we worry too much about the words that we say and was that an MI phrase or not an MI phrase. And so knowing you and you know, at least the spirit of MI was all there.
So we have Dan, and then I think we have another a hand over here at least. So.
Yeah, thanks for this discussion. This is great. I love how in your slide you had a meeting of two experts up there, and that's always been my favorite definition of shared decision making, and it's one of the earliest ones. And I wonder if part of our trouble is we get tripped up by narrower definitions of shared decision making. I'd be curious to hear your thoughts on that. And just to reflect a little further, you know, you mentioned that relapse doesn't fit with the shared decision making concept, and Dr. Epstein yesterday kind of alluded that shared decision making might be inadequate for certain situations. And I just wonder if those comments are just a function of a narrow definition of shared decision making. So I'd be curious to hear your thoughts.
So I'll give you a couple of biased reflections. So I tend to favor a broad definition. If you hear Victor define shared decision making, he calls it creating a conversation, which doesn't sound a whole lot different than how Glenn defined it in his opening remarks. And I think having at least a broad even if we have to go in the weeds in terms of defining shared decision making in certain contexts, having a broad understanding that it's about a conversation that has certain functions to it, and I think is a great starting point personally. But I don't have anything more to say than that.
Well, I agree, and I think that in motivational interviewing, it really invites us to be transparent about what's happening in the conversation and to talk about it. And so I think a lot of times we fuss about, did I say the right exact words? If we can get away with a lot if it's in the right spirit, if it's meant to be, you know, the compassionate care. We can express concern, we can give advice, we can give recommendation, we can say, you know, this troubles me, I have concerns. We can say, it feels like you're doing more, or I'm doing more of the work than you're doing. What's your perspective on that? So you can be frank and directive and give feedback, and a lot of clinicians feel that you're not allowed to do that in MI. And so without being, and when you hear, for instance, Bill Miller do it, just a real quick example, a colleague of mine asked him a question. Bill Miller didn't give him the answer he wanted, came back, asked the same question. It was about, do we need to train nurses to be compassionate? Should we send them to big retreats so that they can learn to be more compassionate? Bill Miller said, no, in the practice of motivational interviewing, you know, empathy, understanding another person's perspective and compassion just grows in the practice. So third time he asked the question, and Bill Miller, and I can't do it the way that he does it, of course, but just in a non-judgmental way, just said, you know, 3 times you've asked me that question and 3 times I've said no. And then he just let that sit there. And we were like, ooh, because it was true. He just said it. It was directive, but it wasn't shaming. He didn't spank him. He just said, hey, you know what's happening in this conversation? You keep asking me the same thing and I keep saying no. And it created this huge efficiency in terms of where the conversation went then. And you know, it was the tone and the spirit. He wanted to make sure that my colleague understood. So he said, hey, you know, this is what's happening right now. And MI and shared decision making and these conversations should be just constant iterations of what's happening now, what's happening in the room, what's happening in our feelings, what's happening with your choices. So I love this choice change, flip back. I'm really excited about that. Because I think that's, as guides for the conversations, we need to continually invite the patient back into the conversation and to observe where this conversation is going. And so I think the broad and the monitoring of the conversation, less about being perfectly strategic about which words we choose, and more about the monitoring and guiding with the right spirit. And that we can say things, we can share our concerns, and and give advice and recommendations. It's how we do it.
Yeah, we've got a very long-suffering person who's had her hand up for a while. So.
No, I'm not suffering. I'm really enjoying this. One of the things that I enjoyed over the last few days is the emphasis is being placed on context in the shared decision-making world. And so that brings to mind, in this particular conversation, if you were to integrate MI and shared decision-making, what do we do about this context?
I'm interested in your ideas. That's a great question. What are your thoughts?
Well, one of the things that I liked about the past few days is that one of the aspects of context is, for instance, I work in the field with elderly people, and you often have them, if they go to any clinic or consult, there's always a family member with them. Mm-hmm. So you always have to deal with them, or you can use them, or they can use you. And the impression I had of your MI presentation is that it feels to be very much a dyad thing, whereas in SDM, many of us are moving away from this dyad. And so that's one of these aspects of context.
Well, motivational interviewing, and I usually describe it as coaching conversations, because that's a little bit more the world that I live in primary care. I don't say they're motivational interviewing only conversations, but we say coaching conversations, and we do have them in groups, and so groups of patients, family. So the same spirit is there. The role of the clinician continues to be in guiding and monitoring the conversation, which might mean bringing the support person in more, or guiding, if that person is overtaking and the patient is not able to express their own opinions, it's guiding the conversation and inviting even more. So I would say that the very same communication basics are appropriate across these different contexts and different cultures too. We talk about there are, just really quickly, the patients that I work with in one study that have COPD, they're very ill, they're elderly, out of the hospital, they are not used to these conversations. And they'll say to me, am I giving you what you want? Is this what we're supposed to be talking about? Am I doing this right? And there's this real concern about, this conversation isn't like other conversations. And so even having a conversation about the conversation and the identities and the roles that we have, because sometimes we just come back from a conference and say, I'm going to do MI now with patients, and they don't, they might not know where this is. It doesn't feel right, or it feels different. Especially this particular group of patients needed some reassurance, and we had to have a conversation about the conversation. So I think it's a very flexible approach, and it is patient-centered, and the patient is looked at in the context that they are not just a patient. Just like with self-management support, that this person is part of many different circles in the context of their life and their different roles.
Yes, I'm particularly pleased with your last case that you mentioned about taking it a step higher, because I think, and that's probably not just applies to elderly people, but just asking about what did you think of the conversation, because that's a limitation, I think, and its strength, of course, but also the limitation of both shared decision-making and MI. It's all about talk.
Yeah.
And of course, there's also this rapport, but it's all about talk. And we are much better at it.
Yeah.
As researchers, as clinicians, we're all much better than our clients. So I don't know what to do with that, but that's so there's also our own behavior that we should put into it.
I agree, and I think that if that's a safe part of the conversation too, I think of one gentleman in the study, he said to me, I'm a better listener than I'm a talker. Mm-hmm. And then, and I said, does this feel weird? I keep asking you all these questions. He said, yes. What are you getting at here? And we just talked about that, and I said, well, here's what I'm interested in. I want to know what's going to work best for you when you get home. I don't want to just tell you what to do, because I don't understand everything about what happens when you get home. But if you prefer it, I could certainly lay out some options of what other patients have felt to be helpful, and you could just react to those. Just even maybe it'll be none of these, but just get a sense of if any of these are, and that's what we did. It was a lot more of menu of options choice, menu of options choice, and then once we were in the, he found something that made sense, he was doing a lot more talking. And then we refined it and made it his. And a woman that I work with who helped train me in motivational interviewing says with adolescents, you do a lot more, because MI is evocative, you're pulling, but she says in their interventions, they're getting a lot of, I don't know, doesn't matter, whatever. And so, these conversation stoppers happen, and so what do you do then? And so it's a flexible approach where you don't just sit there and some people won't feel comfortable, they won't know what to do, what to say. We are the guide, so then we help. And that might mean talking more for them, giving tools, giving options. Yeah, it can't be the same approach with everyone.
Thank you.
One last remark.
Just as the conversation went on, it seems like you're flipping back and forth between physicians as advocates versus physicians interacting in a more sensitive and rich way. And I wonder if whether it's motivational interviewing or shared decision making, just reflecting my own practice, the less time I have for the patient, the more I tend to advocate for health and make very sort of quick, objective decisions. And perhaps these tools or approaches, when I walk into a patient room and I see what their chief complaint is, they suddenly become three-dimensional and very rich and very much more complex. And I find my desire to advocate solely for health starting to be put into perspective. I'm starting to advocate for the individual, and then the health is just the expertise that I've been trained that I can offer them as they need it. But just there's something about this dynamic that I think we as physicians and patients want. It's just how do we get there, and these are some of the skills to consider.
One thing I've been thinking as the conversation's gone on, this, at least in my training, and I think this is true of most clinicians, we're given no guidance in how to create space for our own emotions and how to negotiate those. And it's, I think my knee-jerk response would be, I've gotten the impression, I don't know that anybody ever said so, but it's inappropriate to be frank or be candid, about the physician side. And yet I have a colleague who would argue that's where intimacy comes from. That's where relationship is built, and it becomes two individuals, a conversation of two experts. We both bring different things to the table. So I wanted John or the audience just reflecting on what is the role of opening up dialogue about clinician emotion and thought and reaction in SDM.
I think that's a perfect conversation over coffee. We've come to the end of our hour, and I think it's a great question. So please join me in thanking our panelists today. I've enjoyed it very much.